Well, I am Dr. Jennifer Sugden. People like to call me Dr. Jen. And I am, this topic area is near and dear to my heart. I have 21 years of experience in the medical field, and my last 3 years of medical school, I did midwifery. So a big majority of my practice early on was pediatrics, and then as it, moved into more chronic complex illness, still within that area, it's still a love of mine. And we're gonna talk about how we can prevent disease in those kiddos and keep mom safe during pregnancy. Excited to be here.
Good morning, everyone. So I'm Yvonne. I have been working with chronic complex illness for about 17 years now. I first started working with Dr. Stephen Harris right out of school. And as you heard, we just recently merged with Gordon Medical. So it's exciting to collaborate with like-minded practitioners. When I first started this, little did I know what kind of patient population I was getting myself into. But, after 17 years now, it's quite rewarding to get people finally feeling better after years and years of illness. And part of that patient population have been pregnant patients that are dealing with Lyme disease. So we will talk about pregnancy and Lyme, and we'll go through conception, pregnancy, delivery, and the postpartum stages.
So first of all, when we have a patient that comes in, we always like to just take a very thorough history on them, obviously. And this isn't particularly important even when I have an older patient, trying to figure out exactly where they may have contracted Lyme, looking at their pregnancy history, potential miscarriages that they may have had, how their pregnancies went in general. Was it easy? Was it hard? And any sequelae that occurred, post-delivery. Looking at those can really help guide us in regards to, where we think how long Lyme or tick-borne illness has been in their system. But in particular, when we're trying to, assess and prepare for conception, what are their potential complications? Have they had miscarriages in the past? Did they have a preterm pregnancy? Are there any bleeding disorders? I like to look at birth control history, as well as being able to allow me to know how long I have. Is this patient safe to treat with some of the medications that I may want to do prior to pregnancy? Do I have any risk that this person could get pregnant in the midst of doing treatment? And so looking at birth control and any of that, risk factor. Certainly their timing is really key for me. When do they want to start a family? And giving us enough time, again, to do testing and or treatment. And then hopefully, and I'll talk about this in a minute, but more of that kind of priming the body for pregnancy, having enough time to do all of those things. And then consideration of other exposures that they might have, not necessarily just looking at Lyme as the only thing that they've got going on. Do we have anything else that we want to look at prior to conception? Do they have mold exposure? Is there a heavy metal issue? Do they have parasites? Is that part of what is creating difficulty in sustaining a pregnancy? That it might not all be Lyme related, but may have other issues that are concomitantly going on. So just not missing any of that history when we're looking at how to make this the best possible pregnancy outcome that we can. You can advance that slide, Yvonne. So testing. So, we've had lots of scenarios coming in. I can think of a particular, couple that I saw where husband had been dealing with chronic complex illness. Lyme was a piece of that, with several co-infections. They got pregnant and had no idea where she was in regards to testing prior to getting pregnant. And so wanted to know, well, can we do testing now? Well, you're 20 weeks pregnant at this point. Very difficult to do testing on a pregnant woman from the perspective of many of our testing is antibody driven. And so at the time of pregnancy, an immune suppression because we're growing a baby inside of us. And so, that's not always necessarily our most accurate way of testing. So PCR testing sometimes is our only option. There's also the consideration of what kind of testing do we want to do. If we had a past history of Lyme tick-borne illness, patient was treated maybe in their teens or early 20s, and now they're ready to have a family. They've been asymptomatic, excuse me, for, maybe even a decade in some cases. Do we want to do testing to just optimize and look at what potential they might have in regards to transmission? And then, of course, any other exposure testing, mold, heavy metals that I talked about before in regards to, do we want to do any other detox components that might be useful at that time? In a ideal, perfect world, we've got enough time to test, to look at those tests, to look at the pros and cons of treatment at that time, but also have enough time to then detoxify this body to really optimize and prime this body as best we can for pregnancy to happen. And I would say that's true with anybody, not just necessarily just chronic complex illness and or tick-borne illness. Ideally, I want that. I want to be able to look at all potential exposures and really optimize this body. 6 to 9 months is a estimation. Sometimes I'll need 18 months to treat and really rebuild the system for conception to be ideal. We oftentimes get this question in regards to IVF. This is not uncommon in the Lyme community because we do have a lot of these folks that have difficulty in getting pregnancy and or difficulty in holding pregnancy. And many scenarios that can happen within this, situation. And we'll get into this a little bit in postpartum as well, but, changing hormones, shifts of hormones within the body can create a resurgence of Lyme and tick-borne illness. And so, or reactivation, maybe that's a better way to say it. And so, certainly with IVF, we're throwing a fair amount of hormones in purposefully for what we're trying to accomplish there. And do we need to support the body either through antibiotics or maybe an herbal treatment during the timing in which we do IVF treatment to keep the immune system on guard and keep these bugs at bay? There may be more questions that come in specifically in regards to that, but that's kind of our starting point in regards to that discussion. And Yvonne will get a little bit more into the treatment options that we would have during pregnancy.
Great. Good. So now you're pregnant. What do we do? Do we treat or don't we treat? Now, first off, mainstream docs, CDC, they do not consider Lyme disease to be transmissible during pregnancy. However, we have seen enough cases, enough families, enough couples that, we think that the possibility is there. Now, it is possible that, the kids, the mom, they all got their own tick bite. But again, we just see enough cases that there likely are these other sources of transmission. So back to, do we treat or not? So there's a lot of things to consider. So for example, the health of the mother. How symptomatic is she? Does she herself need some treatment for her symptoms? Is she going to be able to tolerate antibiotics? What is her gut flora? Is she susceptible to yeast infections? How long has she been in treatment for? Is she symptomatic? How long has she been asymptomatic for? What is her current test status? Is she still showing positive on paper? However, she's not having any symptoms right now. So a lot of things to consider, and there really is no right answer. We don't really have a set guideline for that. So I think it's really important to just discuss the risks and benefits with your patient, and to consider all that. And so if a patient does decide to proceed with treatment during pregnancy, what do we treat with? We typically will use antibiotics. Homeopathy is okay, but as far as herbal antimicrobials, certain supplements, we really do cut back on that during pregnancy. Really, less is more. We just don't have a lot of safety data regarding some of the supplements and herbals. We generally do take them off quite a bit. All right, so if a patient does decide to use antibiotics, which ones do we use? How many do we use? Again, that is a discussion with your patient. The late Dr. Charles Ray Jones, he was a pediatrician, saw a lot of the Lyme children and their mothers. And in one of the conferences, just in passing, so it was not a formal study, he had mentioned that there was probably, in his experience, 50-50 chance of transmission if the mom was not on treatment, about 25% if she was on one antibiotic, and less than 2% chance of transmission if she was on 2 antibiotics. Now, in my experience, that 25% is probably a little high. I think it's lower than that. And so, which medications to use? If we use one antibiotic, we would typically choose one of the cell wall drugs. So anything in the cephalosporin family or the penicillin family. So for example, cefuroxime, 500 milligrams twice a day, cefdinir, 300 milligrams twice a day. Cefazime is a nice one because it's just 400 milligrams once a day. So compliance is better with that one. And if we were to add a second medication, we typically would use azithromycin at 500 milligrams a day. Now, again, consider the patient. How symptomatic is she? How much treatment does she need? Can she tolerate these doses? So that's all really important to remember. The antibiotics we use, they are considered class B for pregnancy, and class B meds are those that have been deemed safe through animal studies. We typically don't use the class C, and we definitely don't use class D. And as far as medications, they come in the oral route to intramuscular, intravenous, and which ones do we use? I think there's a lot of risk to the intravenous, and again, considering how sick the patient is and what kind of treatments she needs, but we rarely use the IV route. Intramuscular IM is okay. Bicillin, Rocephin, those are all pregnancy safe. However, we typically do stick to the orals. I think there's just less risk to it. I know a lot of patients are considered about their gut flora, but that's something that we always discuss with the patients. I think that's it for antibiotics. I'm sure there'll be some questions, but we can get to that at the end. All right, now as you approach the end of your pregnancy, really prepare early. Talk to your OB, make sure they are aware of what we would like to do. If they have any questions, I always am open to talking to them about it. Have a test kit ready. We will typically use IGeneX. You can just call them and ask for a newborn test kit. And we'll get into what we usually test for. But one of the things, if the OB seems to be pretty open about what we do, is oftentimes I'll ask for a dose of IV Rocephin peripartum. And I think this just helps give the patient a little extra. As the baby's coming down the birth canal, as mom is delivering with all the hormone changes, those are all potentials for her symptoms to flare. So just giving her a little extra dose of Rocephin. She's in the hospital. It's easy for them to do. OBs have generally been pretty open about it. And again, talk to the OB early. Have this test kit early because you never know what might happen. You might go into preterm labor. So if you have this test kit, the things that we generally do test for, we will ask for samples of the cord blood, cord segment, a placenta fragment, and if it is a boy being circumcised, we will ask for a foreskin sample. In IGeneX, they can run these PCR tests on these miscellaneous samples for Lyme and a relapsing fever Borrelia. So on the requisition, you'll just mark it where it's the miscellaneous sample and then just write in what types of samples these are.
So now we have baby and mama here, safely. That's the goal. And so really now I come back in again with a lot of history. How did that go? What was the pregnancy like? I have a patient who, and I think one of the, as I was scrolling through the Q&As, that there is a lot of women that don't know that they have Lyme or, chronic complex illness of any sort, whether it be tick-borne or otherwise, prior to pregnancy. They may not feel the best going into pregnancy, but it's the time of life when they want to get pregnant, and they do, and hindsight always 2020, but super important for me to understand, was that pregnancy, did it change their health history? Again, sorry, I started that conversation or started that story and didn't finish it. This woman came in, 6 babies. She just kept getting pregnant because every time she got pregnant, she felt the best. All of her joint pain went away. All of her myalgia went away. All of her chronic fatigue went away. So let's just keep getting pregnant. That's the answer. Unfortunately, approximately 3 of those 6, I think one had more severe autism, but 3 of those babies did contract Lyme or were positive Lyme, during post pregnancy. So what did the pregnancy look like? That's super important for me to understand in regards to what we do for that mom, post delivery. Do we go back on some sort of major treatment for her if we think that there is a need for more treatment based on how her symptoms were? Sometimes symptoms really exacerbate during pregnancy. They have a horrible pregnancy, but we've treated the whole time. So 9 months of treatment has happened for her. And post-delivery, she feels actually quite good. So any or all situations can arise, and just getting another good thorough history of that time of her in the history is very important to me. The other assessment is, what's her level of depletion? Do I have a major adrenal, fatigue that's come? Now, chronic complex illness oftentimes does, lower the adrenal output purposefully, to be honest. The body does, want the patient down because they're dealing with a chronic illness. But is there a huge exacerbation of this just level of depletion that she has post-pregnancy? And if that's true, where do we put our focus? Maybe less on treatment and more on rebuilding this system back up again. Maybe more, maybe the more of our focus. Any new symptoms that have developed? So, and there's kind of this time frame. This is just a an average. Don't quote me on this for the only time that you're going to have symptoms arise, but in regards to really kind of being mindful, any new symptoms that develop, they might feel, again, fantastic post-delivery, but within a 3 to 6 month time frame, they start to crash again. And making the mom very aware of what she's looking for herself. And then again, with that hormonal shift that can happen when she stops nursing, there can be another period of time where I want her to be much more aware and cognizant of her symptoms. There's always this question that comes up. Now I've done antibiotics for 9 months. I'm kind of sick of it. Maybe they, deal with, and we've got to manage a fair amount of yeast overgrowth that can happen with that. Not always, but can happen. Do I continue antibiotics throughout nursing? Similar to what we can do in regards to PCR testing for all of the tissue samples with at the time of delivery, we can do PCR testing for for the milk sample. I usually will have moms stay on an antibiotic until we at least get that back. Now, if you're on an antibiotic, then it bodes this and it mucks up the sort of vision of what we see here. But if you're on a single antibiotic at the time of nursing, and you give a milk sample, is the PCR negative because you stayed on an antibiotic? Is that the safest route to go? Or do we, do we end up, pulling the antibiotic out, looking at the milk source as, a stable way? I think I did ask IGeneX. I know there was a question that just came in. I did ask IGeneX specifically this question of all of the milk samples that they have seen, how many of them do they actually see a PCR positive? And I was given the statistic of about 20 to 25%. Correct me if I'm wrong, Yvonne, if you've heard anything different than that. But
Probably pretty accurate.
yeah, I think it is far less. Like even if we look at Dr. Jones' research in regards to PCR positive in cord blood, at 50-50, I do think, breast milk is far less, but I still think there is some risk there. And we definitely have seen PCR positive in breast milk. Yes. So now postpartum, more for the baby from the baby's perspective. So of course, all of the testing that was done at delivery, going over those results, looking at pros and cons of making a decision at that time of treating, I think that if we had all, PCR is very specific. It's it is a needle in a haystack. I like to kind of think of it from that perspective. If I've got I reach in to grab that needle in a haystack, which is the sampling of blood, and I miss the needle, it doesn't necessarily mean that the needle isn't there. But I think if we did a few different sample, and that was the point that Yvonne was trying to make as well. If you've got the most tissue samples that you can get at the time of delivery, the better, so that we can really optimize our chances of seeing this. And if all of those come back PCR negative, I don't typically start a baby on any sort of treatment, even if mom went in as a positive Lyme case. That's me. I'm sure there are different practitioners that feel differently about it, and it's certainly worth a discussion with both parents. But I think that if the testing was negative, then we sort of let things lie at that point, and we are again very mindful and looking at different periods of time within that baby's life, child's life, in regards to what we're looking for the possibility that we need to treat in the future. It's hard if we've got a PCR positive for parents to look at that little infant and want to just dive right in and start treating with antibiotics. However, we do find this to be the best option. I think the length of time that's treated is definitely more of a discussion that is hard to have, because we do find that treating for 4 to 6 months is ideal. Obviously weight dependent, and we do everything that we can to try and savor and support the microbiome of that infant. I think, we would come from the stance of treating as early as possible is better. Some parents just can't, figure out a way to do that early on. And so, they wait and watch in regards to what that child's development looks like, and then consider treatment as an older, toddler or even teenager in some cases. The longer it's there, the more potential of replication of that bug. And so, again, earlier treatment, in our opinion, has been a better outcome. And I would say for the vast majority, and Yvonne can speak on that too, I would say for the vast majority, I've never seen those kids again. Like if we treated early, if we did unless they had some sort of a secondary tick bite or exposure, I haven't seen those kids come back, with either developmental disorder or a positive test later. Would you say that's true in your experience as well?
Yeah, I would agree. You have to talk to the parents about risk versus benefits. And like Dr. Sugden said, it's hard to see a newborn be on antibiotics, but I do believe that if the baby is positive, if any of those products of conception tissues were positive, that treating earlier is better before it becomes a chronic issue. Now, fixing the microbiome in a sense is easier than treating chronic Lyme. So, I mean, that we can do that after the 4 to 6 months of antibiotics. But I would also say, yeah, we don't see those patients become chronic really if they do enough treatment.
So, what are we watching for in the future for the health of this child? I think that's important too, to have a discussion, even if I've got all my tissue samples that are negative. If a mom knew that she was positive going into pregnancy, treated during pregnancy, did all of the right things, and the tissue samples were all negative, again, think of that needle in a haystack scenario. I still want them to be mindful as they watch that child grow. So, just not ignoring any tests or any symptoms that do come up. Oftentimes you could talk to 10 friends and they, might have 6 of them that had growing pains, for instance. Maybe 3 of those were actual growing pains, but maybe 3 of them were something else. And so just be mindful when your child comes up with consistency in any particular symptom, headaches, joint pain, what we might put in the category of a growing pain, just and or developmental, issues that, boy, they're still really struggling on this level, or they seem to be quite a bit more anxious than all of their peers. Let's look at, is there a potential that something else was passed in utero? And I think that might bring up another good point. We only have good testing, PCR testing for Lyme and relapsing fever borreliosis. There have been, again, looking at the late Ray Jones, that there were likely scenarios of transmission of Bartonella and even babesiosis in utero. We just don't have good studies on this, and to have hard and fast facts to go back to. But some of those more mental emotional disorders can be co-infections that can come up. So when do we test a child, that we want to look at their antibodies? Then you're looking at, depending upon how long a mom wants to nurse for. Our rule standard is 9 months post nursing. We can test the antibodies of a baby and trust that we're getting their true antibodies instead of passive immunity coming from mom. And so, so looking at, okay, should I test early? If there is, and maybe you do a more thorough panel at that point, especially if mom has some history of co-infections as well, and or if there's anything that we're concerned about in their behavior.
I see there's a couple notes about my volume, so hopefully I'll talk a little louder. So hopefully that's a little bit better for you guys. Sorry about that. Just a quick note too about what to watch out for after the baby is born. 2 time frames just to keep in mind, around age 7 and 8, and then around the time of puberty. Those are times that we will see symptoms flare. We have had cases where developmentally they've met the milestones, they were doing well, and then at puberty they started to have issues, they started to have symptoms. So again, 2 time frames just to keep in mind. I know it's a long ways off, but with those hormone changes, that can be a potential trigger for dormant infections to come out.
Very good point.
All right, I do see a couple questions, but I just wanted to go over some frequently asked questions, those that we get asked quite a bit when we go into this discussion about Lyme and pregnancy. Um, Patients will ask if it's okay to not treat during pregnancy if mom is asymptomatic. And all of these, really, it is a discussion of risk versus benefits with the patient. However, just because a mom does not have symptoms, that does not necessarily correlate to mom not passing the infection on to child. So we have had, again, cases where it's actually two kids that are found to have the infection. And again, they could have gotten their own tick bite, but then we test mom. She's healthy, no symptoms, yet she tests positive for Lyme. So of course, because she was healthy, she didn't look for it. So she was this asymptomatic carrier that likely then transmitted to her kids. So is it okay to not treat during pregnancy? I, again, talk to the patient about it, but just because you're not symptomatic does not negate the fact that it won't get transmitted. Another question we get asked a lot is, does the risk of transmission relate to how sick the mom is? And that kind of ties into that first question. And I would say no, because we have had healthy moms still have found that the kids are symptomatic or have infection. And a lot of those patients have come to us, and then we figure that out after the fact. How many years out from a negative test is it okay to not treat during pregnancy? That's a hard one to answer because there's no set rule. So if you're 1 year out, healthy, no symptoms, and you test negative, I can't for 100% positively say that you're good, you're safe, you don't have to treat. I can't say that if you're 3 years out. We just don't have a test of cure. Are you testing negative because you truly are done with the infection, or are you testing negative because your immune system just doesn't recognize it because your bacterial load is down? So again, there's no set rule on that, but if you're 5 years out, 10 years out, you've done really well with no relapse, that's pretty good. And the co-infections, there's a lot of questions about these co-infections and whether we treat them during pregnancy, and we generally don't. In treating during pregnancy, again, less really is better, less is more. We just try to really, Lyme is the big one that we focus on. The co-infection treatments also, many of the medications are not safe during pregnancy. A Babesia treatment does get brought up quite a bit. Atovaquone, Mepron, or Malarone. There are some practitioners that use this medication during the second and third trimester. I usually don't. I actually don't know if I have. There have been patients that have asked about it because their Babesia is, pretty strong. But it is considered a class C medication, where class C is, we don't know. We don't have enough studies to say that it is safe during pregnancy. So again, as far as co-infections, can they get transmitted or not? We just don't have enough studies. However, what I say through experiences, we do have families that seem to be the Babesia family, or they seem to be the Bartonella family. But with treatment, we just don't have a lot of options for that.
The other thing that Dr. Jones used to do with Babesia in particular, and those using Mepron or Malarone, waiting until mid second trimester or third trimester. You may have said that, but I missed it. And I think I've only done that once in 11 years. So, and it was a very positive Babesia case going in, and she was very symptomatic throughout the whole pregnancy. So, it's certainly a discussion and pros and cons and risk, going into it.
In addition to that, I would also just say, because it is class C, just get a consent, write up a short consent,
Agreed.
get it signed.
The only other thing that I would say we haven't talked about, Yvonne, is herbs. Because we are, we do functional medicine. We have a lot of options in regards to treatment, certainly of an adult, but this is an area where we just don't have a whole lot of studies done. for obvious reason, not many people are going to sign up. Hey, I'm pregnant and let's, be on this herb for 9 months and see what the outcome looks like. That's just not going to happen. So there just isn't enough safety and efficacy of using herbs during pregnancy. There are certain things that I might ride a line on, but to be honest with you, it's much more common that we would consider homeopathy, and some of these, safer Western medicine drugs, as an option for treatment, just so that you know.
Yeah, there's a question in the Q&A about that. Have you seen success with only herbal route in addressing Lyme and co-infections? Um, Aside from pregnancy, if we were just treating our chronic patients, we have seen, how you define success, but we have seen patients get better without having used antibiotics. They do respond to herbal antimicrobials. They do respond to these alternative treatments. They can become symptom-free, but as far as pregnancy, just as Dr. Sugden was saying, is we generally don't. We just don't know enough about them during pregnancy, so we use the antibiotics. Okay, so like mentioned earlier, Dr. Sugden and I, we just joined Gordon Medical Associates from Pacific Frontier Medical. This is our contact information, so that you guys have it there. But hopefully our talk today, you guys picked some, little tidbits up, and I guess we will open it up for questions or go through the Q&A.
So if you're interested in making an appointment, getting a discovery call is the best way to reach us. It looks like there was a couple. I think I had answered the one in regards to transmission that I've seen or have heard of in milk. I would go back to, even, I think that same question came in regards to, statistically. I do actually see Dr. Jones being very accurate with the 50-50. If you did no treatment, that there's about a 50-50 transmission that we see, PCR positive, on tissue samples at the time of delivery.
There's a question here about which specific test are we referencing when we talk about mom testing positive or negative. So the different tests out there, we can do PCR testing, but as Dr. Sugden said, it's highly specific but less sensitive. The antibody test, there's the IgM response and the IgG. There's discussion about what this IgG can mean, whether that's chronic or past infection. So I do think you have to take the patient's history and symptoms into account there. And if it's still an IgM positive, that typically does mean that there is still this active infection. So I think if it's positive in either of the scenarios, it is that discussion of should she treat or not during pregnancy. Now, some patients, given their history of dealing with Lyme, they come back after 3 years of not being sick and got pregnant, and they want medications. They want to do everything that they can to try to prevent a potential transmission to occur. And that discussion becomes a little bit different, where it becomes, you're doing well. You don't have symptoms. You haven't had a relapse. Should we really put your body through 9+ months of antibiotics? And some are pretty determined that they do, and they know the risks of it. And we will.
We had a question in regards to, you had transferred, in vitro, the Lyme to your child. Now that child is grown, what's the potential that this daughter will transfer Lyme to her future children? Really, it's about, getting a good thorough history. Is there any sort of, symptomology that she's having at this time that we have concern that she, could still be dealing with Lyme and or co-infections? And then probably some thorough testing. Now, IGeneX is definitely our go-to for any sort of antibody, IgG, IgM. But in that scenario, I might even consider a T cell mediated immune response, where you're kind of looking at just generalized activity within the immune system. Is there any replication of bug? Is there any replication of antibodies? And Infectolab might be very helpful in that situation. However, unfortunately, they don't have all of the species that we can test for in IGeneX, or maybe a consideration of both might be, if we're really trying to prevent future offspring from contraction, just as a, as a thought.
There's a
Thorough
question sorry, are you done?
Oh, just thorough history again, just as, I think most important. Lab tests are great, but they are only one piece of the picture. I always think a thorough history is more important than even what's on paper.
There's a question about what happens if the mom's bit during pregnancy. I think that we can also discuss just what we do in general if you get bit by a tick. There's a whole range of what opinions out there about what to do with the tick bite. We generally, again, a discussion, but we generally can treat a tick bite prophylactically, because what we don't know is, did the tick carry infection? Was the tick attached long enough for that infection to transmit? And so the question is, what are the immediate things we can consider doing other than sending the tick sample to see what the tick contained? We can talk about prophylactic treatment. For a tick bite, we will often recommend treatment for about 3 weeks, or at least until that tick sample comes back, and that the patient does not develop any symptoms. And so during pregnancy, we would likely just choose the antibiotics we spoke about earlier, the ones that are Class B medication. So, you might be putting a patient on an antibiotic for an infection that's not there. However, if it's there, treating earlier, the better.
There was a study out of Switzerland in regards to treating topically with Zithromax cream, which we have recommended for many patients who are big hikers and at the time of any bite, to just apply for 3 times a day for 3 days. And it statistically reduced the transmission a little over 60%, which I thought was quite high. So, maybe even just knowing your lifestyle and the potential that you could have that, that might be another angle that you could come at it. It wouldn't negate Yvonne's thought in regards to the, treatment for an early bite. I think that's important too, but just as another safety guard, because I know a lot of pregnant women want to less is more. And so trying to minimize that risk.
There's a couple questions with regards to the husband or the dad. What is the amount of risk the husband has in transmission, and can the dad pass any Lyme on? I would say potentially and indirectly. So between partners, a separate discussion, but can partners pass this infection amongst each other? And so we have also seen and experienced that, we have more female patients. So she gets better, she gets worse. She gets better, she gets worse. I'm like, okay, why is she not holding on to treatment? So we have tested partners before, and just like an asymptomatic mom can have a positive test, we have seen partners to be also asymptomatic but test positive. So in theory, could the husband or the dad pass it to mom? Mom now has it healthy, and then pass it on to child. So in theory, yes. So what do we do if the mom is not the patient, but the dad is? We did have a patient years ago where that was the case. And when they were active, and he was doing pretty well, and we had treated him for several years, but when they were actively trying to have a child, we did put him on treatment. Is that overkill? Maybe. But he was, he had the infection for a long time. He can't remember if he was still testing positive or not, but he did want some treatment. So as they were actively trying, we did put him back on treatment.
I can think of another scenario that we've had where dad was clearly symptomatic early on, chronic illness. Mom had no symptoms at all and never did test positive, but all three children had contracted Lyme. So, it's a question, right? I don't think we have all of the answers. Certainly not. But I do think that to Yvonne's point, in the, relapse of that we do see in a lot of our female patients, looking at the status of the male prior to conception even might be very important as well, given his history.
And I just want to, just emphasize that this is not a foolproof plan. We have seen the risk of transmission to decrease if we do treat during pregnancy, but it's still not foolproof. I had a patient years ago where she went through 2 pregnancies with us. She did the same treatment, same medications. She was actually doing pretty well herself, but one of the babies tested positive, one of them didn't. And so that just goes to show it's not foolproof. However, we treated the one that did test positive, and I haven't heard from them for years. So again, treating earlier, the better.
There was a question in regards to SOT. Again, this would be a scenario of there just is not any studies in regards to efficacy of SOT, even in the best of situations. And that's not to say that I don't believe that there's a time and a place for that treatment. I think that there can certainly be benefit to a lot of people that are doing SOT and even put them in remission. However, during pregnancy, there just is nothing that I could say that would be my go-to treatment option, because there just isn't enough data yet.
There's a question here about the vaginal microbiome, the child's microbiome, and as with all antibiotic use, the microbiome that does change in the gut, in the vaginal area. So I think that is something to take into consideration when you talk about potential treatment. Are they prone to yeast overgrowth? Do they have a history of it? How well do they tolerate the probiotics? Would you treat with 1 antibiotic versus 2? But it does shift the microbiome. But that is also something that we try to support along the way.
Sue asked, when you test children for Lyme around 9 months of age, I just want to be super clear. So if you never did any nursing, so if mom was not nursing or getting human, breast milk from another source, then you could test at 9 months post-delivery. But if they're nursing, then you wait 9 months after they stop nursing before you would test the child for a Western blot, IgG, IgM. And have I seen a positive ELISA along with a Western blot? We don't routinely do it because it's just not as good of a screening tool unless I have a recent tick bite. And I would say in utero, probably even less of a potential that an ELISA is in utero transmission, that an ELISA will test positive.
Early question about how we prepare for the first pregnancy when I have known chronic Lyme. I think Dr. Sugden spoke, about that, just how to prepare, how to get your, health as best as we can before you get pregnant. Obviously, there are times where, you find out you're pregnant, and so then we do what we need to do. But if we can help the terrain, get your gut set, bring down the microbial load, have had some treatment before getting pregnant, that would be ideal.
There's a question in regards to just the immune system. Hopefully, I'm going to answer this in the way that you want me to. So I kind of briefly mentioned that. So as soon as conception happens, you have a pretty significant suppression. Leave that up for just a second, if you will, Darcy. Don't get rid of it, just so that I can read it as I'm talking. But just in regards to looking at antibodies once conception has happened and we've got early zygote stage, then the immune system, I can no longer trust at that point that the IgM or IgG testing would be accurate. So that's where I was trying to, and I would say, I mean, maybe if I caught it at like 2 or 3 weeks of conception, I'd still have some antibodies to be able to look at. That's not typically who I would see. I'd see somebody that's, 6 to 8 weeks, maybe 10 weeks pregnant, coming in trying to, make a determination of whether they're going to treat, especially if they knew their status prior to pregnancy. But it does get tricky in regards to how we do testing because of what's happening with the immune shift once we know there is pregnancy. And I can think of a couple that dad was very sick. We knew he was in the active stages of treatment. This was actually through another practitioner, and she was 18 weeks. And so coming in trying to make a decision, she really was fairly asymptomatic prior to pregnancy, but we worried if she had contracted Lyme during the time of conception, would she have a worsening of symptoms and or develop a stronger case of Lyme during that pregnancy? And so it was decided that we would put her on. She didn't want to go on a dual treatment, but a mono treatment of a single antibiotic through the pregnancy. And she had 2 babies, and both were fully PCR negative, even though we didn't start until late in that pregnancy. So anyway, just as a potential, hopefully I answered that question in the way you wanted me to.
There's a question about donated breast milk. I don't believe they test for it. Even in blood supply, when you donate blood, I don't think Lyme is something that they test for yet or screen for. Babesia, I believe they do, but not Lyme. So in breast milk, I doubt that they test for it. But that made me think of one of the scenarios that we had where a patient was actually wanting to use a surrogate for pregnancy. And so we actually ended up testing the surrogate just through the Quest lab, and she was positive through a Quest lab for Lyme on a Western blot. So that was, we couldn't believe it. I think we repeated it because we're like, no way, how did this random surrogate just test positive? Anyway, she found someone else.
I want to say that was the same family. They tested 2 surrogates before they found one that was negative.
It was years ago, but they decided to test, and it was very shocking.
Yeah, and it makes you question, like, how many times is this happening, out there in the general.
How many people out there potentially are carrying the infection but don't know it because they're asymptomatic, they're mildly symptomatic. So then how many of them are having babies who potentially got it in utero and now have developed health issues, and we can't trace it back because they don't know to look for it.
Okay, the from what I understand is risk of transmission with sex very low, moderate, or high. That's a great. I don't actually have a statistic on the percentage. Maybe you do, Yvonne, but they have done testing, that spirochetes are testing positive. You can see spirochetes in the semen and in vaginal fluid. So more common, I think, just for quantity of fluid for male to female passing the infection, but still possible the other way around.
Yeah, I've had, I can recall 2 patients that we tested the semen sample and they were positive PCR for Borrelia. In babies, do you often see the OSPE and B? So I guess with the testing, if we are doing the immunoblot, depending on how long you're nursing for, if you're nursing, so testing after the fact so that we don't get the mom's antibodies. You can also test as long as they haven't been nursing at about 15 to 18 months of age. Honestly, I haven't looked at that closely. I have seen positives, but I believe it's possible. They're the later markers, and so if it's been in utero, if they've had it a year out, they test when they're a year and a half. It is possible to see the 31 and 34.
The question in regards to other symptoms that overlap with Lyme. I'm a big proponent of not everybody that walks through my door that might think that they have Lyme actually does have Lyme or Lyme only, right? That we are not typically just one thing. And so really, yes, looking at mold and other conditions that can have a lot of the same symptom picture as Lyme is important. And if I've got enough time to do more of those detox, mechanisms, Lyme, I oftentimes say it this way, if disease is a spectrum, right, 0 to 100, and you've got 3 diagnoses, there's no guarantee that it's evenly distributed as far as those diagnoses. Lyme could actually only be 5% of the issue, right? 95% is mold or, heavy metals. And so making sure that we are looking at and trying to have enough time prior to conception is ideal to detox from all of those pieces so that we can, really optimize the outcome for you and for baby. Uh,
I think that's the family that you
a
saw.
family that I saw that had 6 babies and she felt amazing. So did I hear that also 3 of those had Lyme? So yeah, it was a pretty one of those 3 had pretty severe autism. The other 2 did have some learning disabilities. All of them were, I think, above 5 years old at the time that I saw her. So interestingly enough, though, I mean, it was pretty miraculous in regards to what we could do with those children that had some disabilities. So, completely nonverbal autistic child that, within a couple of years was speaking and capable of having and being in a normal learning style for his needs, but where he really couldn't fit into that situation in a school setting at all. So yeah, it was about a 50-50. She didn't know that she had Lyme, obviously, and about 50% of her children had contracted it, and 3 of them were more affected. That had Lyme were symptomatic. One of them being the worst of those 3.
I'm just looking at the chat now. And Sue, thank you for that comment about the CDC recently updating their website to recognize the neurotransmission. And I also see that you have posted some evidence of the congenital Lyme. So thank you for that. And yes, I would agree that if we can compile, submit our data, publications, I mean, that's what we need, right? In the meantime, we're trying to treat these patients, but studies, research, it is what is needed.
Absolutely. Thank you all for coming and I hope we got through all of your questions. If there's more that come in, Darcy, please let us know. We'll try and get those answered for them.